Yeah, good evening everyone, and welcome to today's online webinar session on GI bleed. We have Dr. Sayesta, emergency physician, Yashoda Hospital's Malakpet, who will be sharing her valuable insights and knowledge on UGI bleed. We look forward for an engaging session, ma'am. You can join, ma'am.
Good evening, everyone. This is Dr. Shayesta. I work as a senior registrar in emergency physician at Yashoda Hospital's Malakpet. Today, the topic of discussion for this webinar is gastrointestinal disease. Let's start. Okay. GI bleed is classified into two types, upper and lower GI bleed, according to anatomical site of origin, basically. And this demarcation is marked by anatomically by ligament, basically a suspensory ligament of duodenum that marks the duodenal-jejunal junction. Anything about that, bleeding from anything about that is grouped under upper GI bleed. Anything lower than that is lower GI bleed. Let's start discussing the upper GI bleed first, and then let's go to the lower GI bleed separately. Okay. Starting with the pathophysiology of upper GI bleed. Basically, the most common cause of upper GI bleed is peptic ulcer disease. The other causes in order, which follows, are erosive gastritis, esophagitis, esophageal and gastric varices, Mallory-Weiss syndrome or Mallory-Weiss tear, Dieulafoy lesions, and AV malformations. Starting with the peptic ulcer disease, about 30% of the cases in ED of GI bleed are because of underlying peptic ulcer disease. Okay, it is the most common cause, and but mostly it is less life-threatening compared to other kinds of GI bleeds. Okay, repeated infection and irritation leads to disruption of the mucosa, which causes erosion of the blood vessel at the ulcer base, leading to bleeding and hemorrhage. The sites mostly include gastric ulcers, duodenal ulcers, esophageal ulcers, and stromal ulcers as well. The next common cause is erosive gastritis and esophagitis. These both combined constitute to about 20% of the upper GI bleed cases, which has predisposing factors or the risk factors like alcohol, salicylates, and NSAIDs. Other less common causes of erosive gastritis and esophagitis are also infection, toxic ingestion, radiation, and stress from many severe illnesses. But these are less commonly seen. Most common causes of erosive gastritis is alcohol consumption, salicylates, and NSAIDs. Frequent use of NSAIDs, like we discussed already. Coming to esophageal and the gastric varices. Varicose bleeding, though it is not that common, it is less common. It constitutes to about 10% of the GI bleed cases in ER. But it has a tendency to rebleed, and the mortality rate in such cases is higher compared to other causes. It is mostly caused by portal hypertension in an underlying alcoholic liver disease. Mallory-Weiss syndrome or Mallory-Weiss tear is nothing but a tear at the gastroesophageal junction at the mucosal or the submucosal level. Typical patient presents with a typical history of recurrent vomitings followed by Predisposing factors include alcohol binge drinking, decay, chemotherapy, vascular maneuver, or recurrent coughs. Next cause line is the Dieulafoy lesions. These are basically tortuous and abnormal arteries, large arteries, which are lying in the submucosa. They, with even the minus erosion in the mucosa, causes bleed. This is the most common site is just near the gastroesophageal junction, 6 centimeters within it, along the lesser curvature of the stomach. Patient presents with massive GI bleed, intermittent, but there are no any predisposing factors because this is basically an anatomical variant. So underlying causes like alcohol or any liver disease, patient do not show up with all those. Coming to how to diagnose the cases of upper GI bleed in ER. The most important factor is the history. Basically, the history gives us a clear indication of which type of wheel bleed it is and what could be the possible cause. Depending upon, first we have to differentiate whether it is an upper GI bleed or lower GI bleed. Upper GI bleed cases usually present with frank hematemesis with frank blood, red colored blood or coffee brown ground emesis. Okay, and a patient presenting with melena and who is under the age of 50 years old is more likely to have an upper GI bleed than a lower GI bleed. Mallory-Weiss tear is a typical presentation, like we've already said, recurrent vomitings, retching, followed by hematemesis. Any patient with an aortic graft history, such if presenting with hematemesis, we have to consider an aortoenteric fistula. Patients who are at high risk of VIB are those on anticoagulants, salicylates, and MSAIDs. Melena always, dark color stool is not always blood. It can sometimes patients who are on iron or bismuth supplements can present with melena, dark colored stools. That has to be ruled out first before jumping into the conclusion of a GI bleed. Coming to examination, okay. The first examination point of view, the type of vomitus, if needed, if the patient is in ED vomiting, the vomitus has to be examined, whether it is frank blood, brown blood with speckles, or is it something else? The patient is confused because sometimes what happens, they come giving a history of brown color vomiting, but it's not actually blood. So examination of the vomitus, if present, sometimes they come up with pictures. So it's necessary to examine that before jumping into a conclusion of GI bleed. Second examination, once the diagnosis is confirmed, the thing that has to be taken care of, the patient might go into shock. So any signs of shock, like colon clammy extremities and all, has to be noted and taken care of immediately. Hypertension, patient might be in shock, hypertension, and there may be tachycardia there. And there might be other findings on clinical examination, like spider angiomas, palmaethemias, jaundice, gynecomastia, all of it suggesting an underlying liver disease, which gives an idea about the cause of the GI bleed. Any petechia or purpura similarly suggests a coagulopathy. On abdominal examination, any tenderness, mass or ascites or organomegaly can be figured out. In patients presenting with melena, rectal examination has to be done in order to look for any presence of blood in the rectum. And if present, then the appearance has to be noted down, whether it's bright red, maroon, or it is melanoid. That was clinical diagnosis has to be made basically on the history and upon our examination in the ED. The investigations which back up all these things in the case of a GI bleed are you go for a CBP and especially to check for the hemoglobin levels, because patient with a large amount of massive GI bleed might land into anemia, might be transfusions. So, and patient with underlying coagulopathy disorders, platelets has to be checked. LFT for liver disease, coagulation profiles, PTINR, renal function, 1-creatinine ratio should be checked, and if more than 30, it's alarming, and lactate level has to be checked. If lactate is elevated, patient is in sepsis, and there is a high risk of mortality involved. Barium contrast studies are usually contraindicated because if there's an angiography or any endoscopy planned ahead, then it might cause hindrance to that. Nasogastric lavage. Usually when endoscopy is planned, a nasogastric lavage can be helpful to clear out any blood or anything is there in the abdomen to give us a clear vision. But it has to be done only in selected cases, not all cases of upper GI bleed. We can put a Riles tube and do nasal lavage because there's a high risk of aspiration or GI injury during that. Then we have scores, Glasgow Blood Sport score, and the AIM-65 score and Rockall score, all three of which helps us to identify the severity of the disease. They don't help us to get to a diagnosis, they help to decide the severity. Like, for example, if in Glasgow Batchford score, we consider all the lab values like blood urea, nitrogen, hemoglobin levels, and blood pressure, basically with underlying other conditions like hepatic disease, heart failure, all included in this, and and score anywhere more than 0 indicates the patient needs intervention. Any score anywhere more than 8 indicates the patient needs an ICU admission with higher chances of rebleeding. Rockall score also helps us to estimate the risk of patients. Like if the score is less than 2, it is a low risk. Like the patient can be put on oral medications, and hospitalization is a must for every patient with GI bleed. Observation is a must, at least for minimum 24 to 48 hours. If the score is 3 to 5, there's moderate risk. That means the treatment will be the same, but the hospital stay increases for at least 72 hours to avoid any complications. And if the score is more than 7, it gets high risk. That means patient needs ICU admission, and there is high risk of mortality involved. Coming to the treatment, patient with a GI bleed, upper or lower, goes into rapid deterioration because from outside it's difficult to elicit how much the bleed is, how severe the bleed is, until we go with the specific imaging and diagnostic tests like endoscopy or colonoscopy. Unless those are done, we don't get a correct estimate of how much bleed is happening or might happen in the next couple of hours. So prompt resuscitation has to be taken up. If the patient is in shock, already in shock, hypervolemic, if the patient is anemic, immediately the patient has to be started on crystalloids, IV crystalloids. Patient blood transfusions, if necessary, have to be started. As mentioned, secure 2 large bore IV catheters. If the patient is hemodynamically unstable, there's tachycardia, hypotension. If the patient is drowsy, then start crystalloids immediately. Once you get the HB levels, once ABG is done, and we have an idea about the hemoglobin level of the patient, then blood products can be started immediately. If the patient has an underlying liver disease or coagulopathy, platelet counts are low, platelet transfusions can be done. And usually blood transfusion is taken up when the HB level is less than equal to 8, actually, less than 9 in older patients, because they might deteriorate very quickly. If INR is raised, platelets less, like we've already discussed, platelet transfusion has to be taken out, FFPs has to be given, vitamin K has to be given if INR is raised, if there's any coagulopathy there. Tranexamic acid role of tranexamic acid, it doesn't stop bleeding as such, but it has shown, studies have shown to reduce the risk of death in patients with GI bleed. Coming to pharmacological management, proton pump inhibitors are usually given in a high dose. That is because for platelet aggregation to occur in the GI, they need an alkaline environment, not an acidic environment. So the pH has to be at least more than 6. And in order to maintain that, we have to give high dose of proton pump inhibitors. Starting with omeprazole 80 mg start, followed by 8 mg per hour infusion. It is found to be beneficial because it reduces the need for surgery, the length of stay in the hospital, and also the signs of bleeding peptic ulcer disease shows good response with proton pump inhibitors. Next, somatostatin analogs like octreotide. Octreotide is basically a long-acting analog of somatostatin. What it does is it causes planktonic vasoconstriction, decreasing the blood flow to the GI tract, thus helping in stopping the bleeding for some time till definitive measures are taken up. Okay, so the usual dose for octreotide goes like 50 micrograms bolus, followed by 25 to 50 microgram per hour. Next, coming to antibiotics. Antibiotics are considered in patients with underlying liver diseases who are with decreased immunity levels, who are more prone to infections. Okay, so empirically, we have to start antibiotics to prevent any secondary infections, because the chances of mortality increases if there's an infection along with the GI bleed. Pro-motility agents like erythromycin and metoclopramide are also used to enhance the endoscopic visualization. That is, especially if we are suspecting that the GI tract is filled with blood. It helps to clear the lumen, so the lesions can be visualized much more clearly. Coming to the non-medical therapy, endoscopy is used as a diagnostic tool and also as a therapeutic tool. Okay, it can identify the source of bleeding and administer hemostatic therapies. In unstable patient, an early endoscopy is preferred once the patient is hemodynamically stable. And it has to be based. We have a very less window actually. If a patient is unstable, patient is in shock or anything, that has to be taken care of within the first 6 to 24 hours. So endoscopy can be planned uh, early, because early endoscopy, early diagnosis is taken care of, and hence the bleeding can be controlled soon. If there is a delay in stabilizing the patient, delay in endoscopy, the risk of mortality increases in patients like these. Whereas when stable patients are there, we can wait for the next 12 to 36 hours. There is no hurry in such cases. Okay, coming to the hemostatic therapy via endoscopy. In case of varicose bleeding, varicose ligation is done. Sclerotherapy also can be taken up. In case of ulcerative region, clips, thermoregulation, and sclerosant injections are given. Then there is a thing called capsule endoscopy, in which there's a small capsule. The patient is asked to swallow the capsule, which has a small camera in it. It goes into the gut for the next 24 to 48 hours, and it takes pictures of the lumen from inside. It can also be in place of the regular endoscopy, but the downside of this is we might miss the site of the bleed because the images cannot be controlled. We cannot control which images are to be taken because it's the camera is basically on its own. So there's a limitation to this, and along with capsule endoscopy. So usually what the physicians recommend is to go with CT enteroclysis along with capsule endoscopy. This is basically injecting a oral contrast and then clicking the pictures, which gives us a much clearer idea. But these two do help only with the diagnosis, but not with the therapeutic part of it. Then coming to balloon tamponade. Okay, this is a temporary method. Use the second tube. Okay, it is basically has two lumens, a gastric lumen and an esophageal balloon, two balloons. It is inserted like a Riles tube and then inflated. So if there is a sign of bleed over there, with the pressure, temporarily the bleeding can be swallowed. It's not a permanent thing. Just till the patient is stabilized and shifted for endoscopy or some other procedures. It's a temporary thing. It is known to stop the bleeding temporarily, which will increase or decrease the mortality rate, we can say. Coming to surgery, in case of variceal bleeding, there are two types of operations, shunt operations and non-shunt. Non-shunt ones are usually esophageal transection or gastroesophageal junction vascularization. The shunt operations include transmedullary intrahepatic photosystemic shunt procedure. For non-variceal bleeding, percutaneous embolization or subtotal or total gastrectomy are considered. Next, coming to low bleeding. Bleeding maybe from below the ligament of Treece is considered as lower GI bleed. Presentation, patient presents with hematochezia or melena also. Okay. Causes for lower GI bleed. Most common cause is the diverticular disease. Colonic diverticulitis can cause GI bleed. Colitis can cause hemorrhoids, can cause edematous polyps or malignancy. Certain malignancies also cause lower GI bleed. Hematochezia is either bright red or maroon colored rectal bleeding. Melena is dark or black colored stools. Coming to the most important common cause GI bleed, chronic diverticulitis. Here, there is no pain involved. Patient experience melena intermittently over a long period of time. The bleeding is painless. Okay. And 90% of the cases resolves spontaneously, do not need any treatment. But recurrence of bleeding is high in such cases. Those who have with high risk are elderly patients, especially with the underlying medical illnesses, like and those on anticoagulants or taking regular NSAIDs. In such cases, even bleeding from a colonic diverticulum can increase the morbidity and mortality in them. Next, coming to vascular ectasia. Vascular ectasia is basically AV malformation of the colon. Okay. Usually on colonoscopy, these are seen as cherry red flat lesions in colonoscopy. Patients usually present with occult blood loss and iron deficiency anemia. And this blood loss, especially in angiodysplasias, are intermittent and for short duration, they resolve and then they show up again. Coming to ischemic colitic and mesenteric ischemia. Ischemic colitis is the most common cause of intestinal ischemia and usually transient due to pure vascular circulation and high bacterial content. Colon is predisposed to ischemia. Risk factors include aneurysmal rupture, vasculitis, hypercoagulable states, prolonged strenuous exercise, cardiovascular insult, irritable bowel syndrome. Those with mesenteric ischemia, only few patients surgical intervention is needed. Unless there is complete obstruction causing bowel necrosis or any aneurysmal rupture is there. Those cases need a surgical intervention. Most of the cases resolve on its own. Coming to Meckel's diverticulum. Meckel's diverticulum is actually the embryonic tissue commonly found in the terminal ileum. Okay, some of these cells contain ectopic gastric tissue, which secretes gastric enzymes, which erode the mucosal wall, causing bleeding. Diagnosis of a lower GI bleed. Again, the history. Patient presents with melena or hematuria, bright red blood or dark colored blood, frank blood or melena, blood-stained stools. You have to very clearly ask about the frequency and the color, if it's intermittent or if it is there chronically since a very long period, or if there are any clots also seen. Any history of pain or trauma previously, or any foreign body insertion was there, or recent colonoscopy that might have caused any trauma which is causing the bleeding. Everything has to be considered while taking the history. Coming to physical examinations, already discussed, look for signs of shock, hypotension, tachycardia, decreased pressure, tachypnea, cool, pale, increasing capillary refill time. If there is no abdominal tenderness, bleeding is mostly from diverticulosis or angiodysplasia. Any other cause, the patient presents with abdominal tenderness as well. The abdominal examination may disclose thickness. If there is tenderness involved, there might be masses there, ascites or organomegaly as well. As discussed, petechiae purpura suggests coagulopathy due to liver diseases. Rectal examination may reveal the source of bleeding, such as if there's a laceration or a trauma or any foreign body or any masses present over there, any anal fissures or external hemorrhoids. Coming to the investigation part of it, the same investigations, the blood investigations are the same. CBC, coagulation studies, cross-matched blood, prothrombin time, partial thromboplastin time, INR, everything. Bleeding from a source higher in the GI tract may elevate bun levels through digestion and absorption of hemoglobin. If perforation, now coming to imaging, if there is a perforation or obstruction of foreign body suspected, routine abdominal X-rays are helpful to come to a diagnosis. Barium contrast studies are not helpful and can interfere with subsequent emergency endoscopy or angiography. The initial diagnostic procedure of choice, angiography, scintigraphy, or endoscopy. Angiography can sometimes detect the site of bleeding and help guide surgical management. It also permits therapeutic options such as transcatheter arterial embolization or infusion of any vasoconstrictive agents. Scintigraphy is more sensitive than angiography and can localize the site of bleeding at as low rate as 0.1 ml per minute. You can see the images shown over here in CT angiography done, abdominal CT angiography. First image is showing a diverticular hemorrhage on arterial face, and the second one, same CT scan, vascular anatomy leading to the lesion. Okay. Coming to the treatment part of it, plays two large. The mainstay of treatment in GI bleed is hemodynamic stability, treating the shock, making sure that the patient is not going into shock. Basically, that. Again, the same in start the patient on crystalloids, blood transfusion if needed, platelet count is low, you start with platelet transfusions, coagulopathy suspected, vitamin K, and what else do we give? FFPs are given. Blood transfusion should be done based on clinical findings and also on the lab values. If there's continuous bleeding, even if the HB is, say, suppose 9 as of now, but there is continuous bleeding anticipated, you start with the blood transfusion anyway. General guidelines for initiation of blood transfusion are continued active bleeding and failure to improve perfusion and vital signs after crystalloid infusion or if hemoglobin falls below 7 grams per deciliter. Endoscopy and surgery. Flexible sigmoidoscopy can evaluate possible distal colonic and rectal sources of bleeding. It allows ablation of the bleeding sites with methods like injection sclerotherapy, electrocoagulation, heater probe therapy, banding, and clipping. Patient with continued bleeding and failure of endoscopic hemostasis may need emergency surgery. Thank you.
Thank you, ma'am. Thank you for your valuable time. You have covered everything related to GA bleed. Thank you for participation.
Thank you for joining.